Hi, everyone. I'm Dr. Faisel Sayed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege. Today, we're talking to Dr. Becca Etz, professor of family medicine and population health at VCU School of Medicine and co-director at the Larry A. Green Center, about putting the person in primary care. Let's dive right in.
Hey there.
Hi, Dr. Etz. Hello, Dr. Dan.
Hey, Dan.
Hey,
Well, it's good to see you again. It's nice to meet you, Faisel.
Yeah, I'm very excited. I've been looking forward to this conversation for such a long time, and well, let's just get right into it.
Great.
We love to meet the person that we're speaking with. We have many students, residents, even doctors who are practice, and we just love for people to hear the story behind your path to becoming a cultural anthropologist and how'd you get involved with primary care.
Sure. So, as a small kid, I wanted to be a family doctor. I declared that in third grade. I practiced my medical doctor signature, which my mother still has and shows to me. Um, and I wanted to cure the common cold and tape apple pies for my troubles. And that was true all through high school and college. I was pre-med in college, but I did that nerdy thing of following docs around, shadowing them and stuff. And they were just the most depressed, unhappy, um, stubborn people that I had met in a long time. And my anthropology classes gave me joy, and shadowing the doctors did not. So I decided to pursue anthropology. And I did a traditional anthropology degree. I went to New Zealand and I studied meetings of community. And I came back and I was unemployed, writing my dissertation, and I needed a job. And I got a gig as a qualitative analyst at the Robert Wood Johnson Medical School. And that was it. I was on a project with Larry Green, who then became a longtime mentor of mine, with Kurt Stenge, who then became a longtime friend. And we were looking at how practices could help patients with their health behaviors. And all the people working on this project had national stature, and they were able to do things and have an impact on a world, which is something that I never imagined. And I suddenly realized I could use my long love of primary care and my newfound skill as an anthropologist to help heal the discipline I fell in love with. So that's really what I dedicate my career to. So I at the Green Center, named after Larry Green, established as co-directors with Kurt Stenge. Our purpose is to help primary care deliver on its now 50-year-old promise of providing better health to the population with a better experience and in ways that are equitable and sustainable.
My goodness, oftentimes we talk about now, we see a lot of, there's a lot of work that's out there about physician burnout. And now we're talking about, okay, now, my goodness, doctors, it's like a new thing. Doctors have become the patients. How do we heal the healers? But what you're talking about is something that's been going on for quite some time.
It has, the the world of HMOs really changed the world of medicine. And the medicine that I fell in love with from my own family docs, but also friends of the family who were doctors, or our neighbor two doors down who was the chief of the emergency room and would have in 1984 many long nights working with other members of his team on somebody who was incredibly sick and falling apart and they couldn't fix. That later turned to be Princeton, New Jersey, Princeton's first HIV patient. That teamwork and the passion and empathy that they had as they worked on this problem, and what I knew of primary care was really special. By the time I got to shadow doctors and see what they were doing, HMOs had taken hold of primary care with a vice-like grip, and their autonomy and their ability to not have their visit interfered with in terms of having the agenda of the visit set by the patient and them in conversation based on their relationship and their knowledge of that person over time. It changed and it became about templates and flow sheets and logarithms and bending costs. And it wasn't about healing anymore. And that's been a long-term thing. We have anemically supported the world of primary care for decades in this country. And that bill came due during the pandemic. These were people stretched real thin. And I'm a cultural anthropologist by training, so I get a little nerdy about it. And I say, primary care not only was being stretched really thin, but there were two specific things that they were doing that was really bizarre. One was fee for service, which I still don't really understand. If you're paying only for services, people coming in and wanting something specific, you're not paying for any modernization of the work environment. You're not paying for any innovation and discovery and learning and education and research. You're not paying for adapting as the world of health and healing changes so that people don't have any resource to fall back on when changes need to happen. If your payment system doesn't allow for you to upgrade or purchase new computers, how the heck are you supposed to do it? So there's how are you supposed to establish long-term relationships with community resources and local school systems and the public health department if any time that you spend on that is not only out of your pocket, but is time you cannot spend in a paid visit. So you're actually losing money as you spend the money, right? So fee for service was one sort of really kind of strange, quirky thing. The other thing that seemed to really get in the way is the interference with the visit itself. There was a third party introduced into the encounter. It was no longer a clinician, a patient. And the way we set the agenda for that encounter and the questions that we sought to solve were based on logarithms and insurance companies and third parties who would never see either one of the people in the room. And there was a great deal of resentment about that. And it's sometimes hard for people to understand, but I try to bring it to their level and say, imagine if you can, working with a lawyer and having the lawyer's payment be determined by somebody else and having somebody else say whether or not it's appropriate for this conversation to be in person, on the phone, or using email. Like we don't usually do that. Or if you were hiring an architect, to pay the architect based on the number of pages of blueprints that were produced and not actually the building designed on them. It's a very strange thing. We stripped all the professionalism and autonomy out of the craft of delivering medical care. And so they were mad, and they had every right to be.
Oh,
It's gotten worse. So that is the healing. And it's just the pandemic took it like one of those stress balls that you squeeze and the warts and whatever pop out. It was a giant stress test, and it made every weakness just pop out and exaggerate.
we have decades of this culture of fee for service, the culture of the chief complaint, the culture of documenting everything around the patient's chief complaint. And some people who are very clever have figured out how to convert the chief complaint into the minute clinic visit. But for most of us, most of the doctors, even the personality types who are going to medical school, do you see that a certain personality type is going to medical school who may not actually be the best at influencing better
I do.
behavior changes?
Sure, I do. I think it's disturbing to me that we have a generation that grew up during that HMO season.
Yeah.
And so that's their understanding of medicine. I have a lot of hope for the incoming workforce because a lot of the medical students that I've interacted with at VCU over the last 4 or 5 years, they're the hopeful, strong leader, broad thinking types of people that I can't wait to have as my doctor.